Hey, everybody. Welcome. We have to me, we have a very exciting meeting. We're going to be a little bit out of order on some of it because we have some people with other duties and obligations. But we're going to get today at 2 o'clock a demonstration of the new DCF database, and uh, I'm really looking forward to that. Also, we have the healthcare district. I see Dr. Phillips is here to talk about, and it was a last minute thing, and thank you very much. But is this the mobile crisis unit?
Yes. And
Okay, good. That's what I thought.
Lieutenant Fazzino's here with me from PBSO.
Awesome, awesome. And I want to really give a shout out to PBSO. Um, Sheriff Bradshaw always it's kind of like not a joke really, but he says he's got the largest drug treatment and mental health treatment facility in the county, and that is true. So this is very important stuff. Um, and let's start real quickly and go through the list and see who's here. First, from the healthcare district, I see we have you, Courtney, and so you'll represent. Um, Tom Baird, attorney.
I think he's out of town.
Okay. Turner Benoit from Hanley. All right. Ann Berner or anyone from South Florida Behavioral Health Network. You have to reach out to Ann later. Okay. Ariana Ciancio, Delray Beach Police Department. Hi, Ariana. Dr. Anita Kakovez, Executive Director, Community Recovery Hub of Palm Beach County. She's probably going to tune in a little later. Okay.
Al, excuse me, she's no longer with the hub. So you can take her off your list.
Okay, duly noted. Who's running Hub now?
Well, we're about to hire a new executive director. So I can be here as vice president of the board of the hub.
Okay. Okay. Well, yeah. Well, you're usually not on the board, so.
Recording
Okay.
No, I've been on the board for a long time, but okay.
No, not the board. I mean, I'm talking about the Saartf, the task force. Right. Okay.
I have been, never.
Okay. More later. Uta Gasiak, Florida Behavioral Health Association. Uta, you with us?
I'm here, Al.
Hi, Uta.
Hi.
Dr. James Green, Palm Beach County Community Services Department Director. Dr. Green? I think he was with us last Thursday when we had our special legislative meeting. Okay. Tama Beth Goodman, attorney. Diary that I need to talk to her, please. Kelly Lee, I saw you're here. Hi, Kelly, from DCF, the department.
Hi, good afternoon.
And you're going to have some other people showing up at 2.
Oh, excellent, excellent, excellent. Thank you.
Okay, Jeff Lynn, attorney.
He said he was going to be late.
Yeah, he's gonna be late.
Okay, good. I definitely want him on at 2 o'clock for sure. Nancy McConnell, Rebel Recovery. Okay, Neil McGarry, Florida Certification Board. Neil? Okay, Michael McKeah, Oxford House.
I'm here, Al.
Hi, Michael.
Hello.
Dr. Robert Moran.
I think also Dr. Moran can be taken off the list. I think he closed his facility. I don't know if he's still.
Yeah, I was just going to say I need to reach out. I meant to do that last month. Okay, Dr. Rachel Needle, licensed psychologist.
I'm here.
Hi, Rachel. Houston Park, Florida Department of Health. Terrell Pyburn, Coconut Creek, City Attorney.
I think she's gonna be late.
She's gonna be late?
I think so.
Okay, all right. Okay, Susan Ramsey, yeah, you're here. Okay, double hat, three-cornered hat. Michael Schlossman, CEO for.
Hi, Al, I'm here.
Okay, great. Terry Shapiro, Executive VP, GIA, Miami and Vita Recovery. Terry? You reach out to him, please. Thank you. Nikki Soda. Okay. Dr. John Simonides, Florida Health of SM. Okay. Alton
Now,
Taylor.
he's here. He's just having trouble with his, I see him there.
I thought he was here. Okay.
Yeah, no, he
All right.
is here. He's just not doing well with this.
All right. Alton Taylor, Drug Abuse Foundation.
Stephanie Thompson for Alton.
Okay, thanks, Stephanie. Jan Toman, Florida, South Florida Opioid Alliance.
Good afternoon, everyone.
Good afternoon. I saw Dr. Lori Vinacore
Yes. Hi, Al.
and Greg Weiss, Commissioner, Palm Beach County Commissioner. Or Niels, anybody from Commissioner Weiss's office? Okay. Do we have anybody here from the Attorney General's office? I know there's been a replacement for Richard Worms. Anybody here? No? Okay. Eric Urlano, Integrity Billing.
I'm here. Sorry for my absence. Been suffering from a couple back surgeries, but I'm walking now.
Eric, I'm delighted to see you back.
Thank you. I check
Okay.
in with you once in a while on phone, though.
Okay.
Thank you.
We're going to go because I know that Dr. Phillips, you have another commitment. So we're going to do the other updates after the healthcare district. And so if you want to begin, I know you have a PowerPoint for us. And unmute yourself.
Hi, everyone. Thank you for having me. And it's always a pleasure to be at this meeting. Great work is done here. So thank you for letting us go for time's sake today. All right, let me share my screen.
Hold on, doctor. I need to stop sharing mine.
Okay. Can you all see what I'm presenting?
Yes.
Okay, I just want to make sure, and it's taking up the screen. Okay, so Al asked us to come speak particularly about some of the work we're doing with Palm Beach Sheriff's Office, and I'd like to introduce Lieutenant Fasino from Palm Beach Sheriff's Office, who's been working with Captain Foley and Sergeant Hernandez on not just, it sounds like the targeted violence unit and also the crisis response team. Lieutenant Fasino, could you come off mute and introduce yourself?
Hello there, everybody. I'm Lieutenant Fasino. Yes, I am working as the XO under Captain Foley for TVU and the crisis response team, and I'm glad to be here.
Great. And I hope, Lieutenant, you can add your piece into it as well, because this is a true partnership between us, and it's been a wonderful one at that. So I'll be sharing some data, and I think, Lieutenant Fasino, please come off mute if you want to add anything in.
Okay.
So I just want to talk really broad strokes for some of you who are new to this meeting. A lot of you know what we do here, but healthcare district is a taxation district that provides gap care for all sorts of healthcare conditions throughout the county. And we have Trauma Hawk, we have all sorts of different, we have Lakeside Medical and Healy, which is a skilled nursing facility, but we have 9 brick and mortar clinics at the current moment that provide all of the services as shown on this page. This is our brochure, but we're part of a bigger system. And so I say that because integrating mental health and substance use care into medical systems and law enforcement and social services is very important to us. So it gives us a lot of perspective on how to do integration and how to work with groups that are doing different work than us, but still serving the same population. And I just want to point out that we, for the 7th year, have gotten top 10% of all federally qualified healthcare centers in the country based on our quality metrics. And this is the first year we got the behavioral health quality stamp, which is a big deal. It was hard to get. We couldn't get it for a couple of years prior. So we submitted quality to show that. And we're proud to present that to our county as something that we strive for excellence. I also say that I actually attend the healthcare district for my own primary care needs. It's a great place to go if you haven't, and it's a great resource to our community. Just also for general knowledge that we offer, sliding fee scales, and we have fair costs based on income and family size. There's an assessment that's done for financial needs. So anybody coming to those clinics gets assessed financially to see where they fit in terms of that financial eligibility, but that's done on when people join the clinics. And just to show our reach, we have about 1,400 employees, 600 licensed care providers. That means people providing direct licensed care, licensed social workers, licensed mental health counselors, licensed MDs, licensed DOs, nurses, et cetera. And we're all throughout the county. Just to mention too, in terms of access for anyone on this call looking for mental health or substance use care for peds or adults, we're open 7 days a week, 7 to 7 at our Mangonia Park Clinic. A lot of our other outer clinics that have behavioral health services are Monday through Friday, 8 to 5, but Mangonia can be a starting spot. It's right on JFK North's campus. And we bridge to the other appropriate programs, which I'll talk about in a second. But we also have specialty pediatric care. And we've had the pleasure actually of having some of our Palm Beach Sheriff's Office transports were teenagers. So we're able to even see some of those youth in this program. I do want to talk a little bit about our current services because it's very important not just to talk about what we're doing with Palm Beach Sheriff's Office, but recognize the system of care that's being put into place. Not just from us, there's a lot of partners involved outside of Healthcare District that we work closely with, but it's really important to recognize that what we're doing with Palm Beach Sheriff's Office is a part of a system that we're all in this community responsible for building, with an emphasis on a private-public balance in terms of how the system works. So we currently have actually 12 MOUs with law enforcement agencies for drop-off of patients to our clinic that don't meet criteria for Baker Act. They don't need to go to jail, but something's going on with them. And they can bring, we have the law enforcement agents on the ground bring those patients to us. I'm going to show data from that pilot actually here today and some of the outcomes from that. And it's been a great process. And we also have a special partnership that we're going to focus on today with Palm Beach Sheriff's Office as a co-responder unit. So Palm Beach Sheriff's Office provides a vehicle and a special trained detective. By the way, the detectives are fantastic. Lieutenant Fazzino, and they've done a great job. Very wonderful officers doing great work out there. And then we provide a therapist and a peer, and we help cover the 4 regions. We've started with Tuesday through Friday, 10 hours just to learn and get used to everything. And I would say that the program has really matured from January of this year on. It started last August in 2024, but we really started to up our game, I would say, starting in 2025 in terms of our staff being ready. And that is a unit where through 911 calls, where it seems like it's mentally health driven, this unit is dispatched as a secondary. First, officers always go check for safety, ground officers from PBSO. But then this unit is deployed secondarily. I'm going to show data from that to respond to the mental health crisis where the person is at. And you're going to see the goal of that program from a national best practice standpoint is to avoid Baker Act and connect those people, de-escalate the situation in the field, and connect those people to services long-term so that they don't keep using the 911 system for care. And this is for mental health, substance use, kids, adults. So that's really what we're going to be focusing on today, some of our pilots for the crisis response. In immediate care, it's really important to note what I just said, that we're open 7 days a week, all ages. We have a specialty pediatric mental health group that I'm going to share in the next slide. We have substance use care and mental health care. I will not hire a psychiatrist or therapist on our team who's not willing to treat all of it. We need to be generalists. Substance use is a chapter of the DSM. It needs to be treated similar to the other things, and it needs to be kind of part of the continuum of care. Most patients with substance use disorders are also struggling with medical and mental health issues as well. So we have that. And we do integrated behavioral health care in all of our clinics. And we're working on care coordination. Care coordination is newer for us in terms of really getting involved in the social parts of care, but it is as important to me as a leader. I know Dr. Andrick's on this call, what people place and purposes after their care as their medications, as their treatment, as their therapy. So I say that because if we don't integrate well into the housing systems, the social systems, the recovery systems, and we don't talk to those people and they don't talk to us, we're missing a huge piece of the pie. So that's a big part of our strategy right now and focus. Very specifically, we've invested in getting all of our teams on Oscars, which is the countywide social system, so that we can talk to each other. We have case conferences and things like that. And then I just want to highlight our access points and our provider types. So you see we have 8 psychiatric providers now, 4 MDDOs and 4 ARNPs. and physician assistants. To see adults and children, we have around 16 mental health professionals. These are therapists and a pediatric psychologist we just onboarded to hopefully help us do neuropsych testing for kids for diagnostic reasons, and to help kind of determine what's going on. I put the pictures of our pediatric team that's actually located at Atlantis. That's right next to John Prince Park and right next to JFK Main Hospital. Dr. Wicks is our fellowship trained child and adolescent psychiatrist. He also speaks Spanish. He's comfortable with kids, teens with addiction. I want to say that because he did a lot of training with us on addiction and he's comfortable managing and treating them. We are seeing a lot of cannabis use in our teens. And then you see our other providers here, and they're integrated inside a pediatric primary care clinic. So a child can go and get, help with their medical, their physical, and their dental actually in that clinic. So it's important. I just wanted to highlight our pediatric services, even though a lot of what we talk about is at this Mangonia's location. We bridge the kids from Mangonia to this Atlanta site, and that's one of our newer service lines. In terms of data, I just want to share with you what's happening with us. So we've expanded our workforce, like I showed in the previous slide, pretty much doubled it, almost tripled it in some areas. And the reason for that is we're trying to move a lot of systems of care upstream. So make sure there's access to the lower levels of care so that Baker Acts aren't being used to get the lower levels of care. So increase access. This gray bar in January, February, March, April, May represents our volumes of visit volumes in 2023 for behavioral health only. That would be integration, psychiatry, therapy, and some of our substance use services. The green represents the month this year. So what you see here, and I think it's important to point out, is that we are month over month from last year seeing much more increased volumes for mental health. I think that's a result of marketing, but also having an increased workforce and getting the word out that we're available for these services. There's a lot of other interesting things on this slide, but I can, that's really what I wanted to say is that our increase in resources is matching the demand of the community. The other thing is I broke the same dashboard out into 0 to 17-year-olds, so kids and adolescents, right? You see our volumes from last year are way up for youth mental health, and that's a good thing because we hired a whole team. I will tell you on the adult side as well as the pediatric side, we still have a lot of capacity on our schedules. So if there's people out there who are looking for help with substance use, mental health, adult or pediatric, we still have a lot of ability to see them fairly quickly. And so it's just an important thing to note that we're matching the community, but we still have room to grow to support those patients. And just to focus on what we're here to talk about today was how we're integrating across law enforcement agencies. So you guys have seen this from us in previous strategic discussions about where we're headed at the district to help with gaps. What you see is a physical health emergency. Most people are very familiar with this. There's a person in crisis, you call 911, ambulance, fire, there's an emergency department, and you can go to an inpatient unit. And if it doesn't need this, people seem to know a little bit better how to access outpatient care. We want to mirror that in the system of behavioral health emergencies, right? So person in crisis, there's a crisis call center. And what I'm going to focus on is our pilot with the PBSO, I'm circling it with my mouse, is on the mobile crisis teams. Now, South County has wonderful mobile crisis teams. We work with alongside them. They refer to our clinic on the north end. They refer to South County on the south end, but they send a therapist. And they work through 988-211. This is from a 911 dispatch. So Palm Beach Sheriff's Office was, and Lieutenant, I was going to see if you could speak about this for a second. The burden of mental health related calls to the dispatch line for PBSO and how much officers are responding to that. I was going to kind of see if you could just kind of anecdotally share that. I don't know if you can come off mute.
Yeah, I don't know the exact numbers, but between the police service calls and the calls for mental health crisis is obviously enormous, especially throughout the day and the afternoon. Currently, right now, we have 5 teams, including the city of West Palm. We've incorporated it into a task force. So PBSO and the city of West Palm are now working together on the same CRT teams. And we're hoping to bring on more cities as we go on. The units will respond with road patrol. They will also be listening to the radio across the county to listen to the calls. Each unit is assigned to a different area of the county, and they're responsible for it, and they will take up on the crisis calls. And roll from there. They will do the evaluate. They will allow the once the scene is safe, the therapist will do the evaluation to see if it meets Baker Act. If not, and then we can transport them for services through our different partners with the healthcare district.
Mhm.
And everything falls right now under the one MOU. And as we bring on more departments, we can probably condense that down to even a single MOU if we're all going to be in partnership and using the healthcare district.
So thank you, Lieutenant Fazzino. So I think we've been operating this since August, and just to make clear, it's a peer. It's actually a healthcare district certified peer. We are developing internally a career ladder for peers. We believe in them. There's no need. They're a very valuable, important part of the team. And we're working with Mental Health America to get them certified. So they're getting certified and they're able to get their supervision hours. And we've actually had some previous patients apply to the position, which is amazing because that's what we need. So peers are with law enforcement as well as a therapist. So, and this is a true co-responder unit. So what happens is the categorization for reason for call. So our team goes out and this is data from our EMR documented from the calls. So as you can see, we've served about 268 patients. Forget about visits. That's just the number of visits that's generated. So there's been some patients that have had more than one visit. Only 10% of those patients were previously with the healthcare district for any services, which means I think we're getting the whole purpose of this is to reach out to people who are using 911 for mental health when they need other services, right? So that's a good thing because we're tapping into a group we haven't previously been able to reach. Most of these patients are housed in a private residence or being seen in that capacity. You see that it's 50-50 male, female, 10% are homeless. That's not that high actually, but you see very highly uninsured. So the way that I would kind of layman's way think about this is it's a lot of the working poor. They don't have a lot of access to resources through insurances, as you can see. And most of the calls start with a 911 dispatch, which is what we want. And sometimes they see PBSO officers 25% of the time actually requesting specifically that the CRT unit come out through Lieutenant and Sergeant Hernandez. But most of them are starting to come through 911 dispatch, and the type of calls are being tracked too. So signal 68, and I believe it's another signal here, are the most common for calling. It's a miscellaneous dispatch type. Signal 20 is more mental illness Baker Act related. That's the second most common dispatch type, and this is the dispatch generated by 911. I've learned from PBSO that sometimes the dispatch call doesn't always match what's happening in the field, as it's hard to figure that out on the phone. Is that right, Lieutenant? So we're tracking this to see if we can start to use this data to find out what dispatch types should automatically dispatch as a secondary response, a crisis response team, right? And not so much hand done through the sergeants and the lieutenants. You see welfare checks, domestic dispute is 8 of them, attempted suicide is on there. So we're tracking this information and learning from it. I can tell you the response time on average best practice for these kind of units is under 30 minutes. And you see that most of them are under 30 minutes response time, which is a kudos to Lieutenant's team. And then we're looking at the time and visit. So on average, it's about an hour, and usually there is really one person on the scene. You also see timing of calls. So I've had to learn a lot about police lingo. An in-progress call means that the person is calling and it's an active call. The person needs help right now. Most of the calls are happening in progress, which is good, 51%. The rest of these, and this is not a 24/7 unit at this time. There's discussions about when that would happen. So it's limited to 4 10-hour shifts. So these are follow-ups from previous in progress calls or follow-ups on our own. But the goal would be to get most of them being done in progress. And that has actually improved in the last 6 months compared to the first 6 months of the program. You also see that we're tracking. I just want to highlight this. From this program, the goal of these mobile units is, again, to de-escalate things in the field, to take away putting people in jail and putting people in Baker Act when they don't need it. You can see here there have been 0 arrests from every single one of those calls. I think that's a huge outcome that's important to track. Not one person when CRT was called was arrested. It's huge. It's a huge less burden to the patient, less to the officer, and it's also a lot less expensive. But what happened is interesting, and I'm very transparent. When we first started the program, the other goal is to try to minimize involuntary transfers and start getting people scheduled in appointments. What you see here is currently we're scheduling more patients. And outpatient scheduled elsewhere means something like maybe the patient had an existing provider at another facility. We're happy to schedule with South County or multilingual or any of those other providers that they're getting care. But when we first started, more patients were having involuntary transfers than scheduling, and it's flipped. And I think that's because of workforce development. Our workforce on the units is, or on the teams is getting much more better at the work and better at de-escalating. Then you can see, so how many actually came back for the appointment scheduled for them, at least at the district where we can track that, most of them 83, 60% are coming back. That's great. We have a round of 50 to 60% no-show rate for new patients who schedule over our call center. So to have 60% of patients coming from this system show up at their follow-up appointment is huge. And again, I think a kudos to the engagement that's happening with the detective, the peer, and the therapist in the field. So this is a work in progress, and you can see about 57% of the patients agreed to whatever the disposition was. There's still more engagement, and a lot of times the unit will go back for a second visit to build trust with that person if it feels like that's an important intervention. But it's growing. I think we're growing in our size, and we're also learning a lot from this early years so that we can continue to improve the quality of the program. One final comment is to show that only 7% of people had a situational complaint or a symptom-based complaint, and about 93% had situational and symptoms going on. When I say symptoms, there's psychiatric symptoms and there's situational stressors for most of these patients. But I'm going to pause there for a second to see if Lieutenant Facino wants to add anything to this, and just really make a comment that PBSO has been a wonderful partner, and I'm amazed with all the initiatives they're doing, forward thinking they're doing around alleviating PBSO being the biggest provider of mental health. Kudos to you all. So I don't know, Lieutenant, do you have anything additional to add?
Just that if you would ask me 10 years ago if we were doing something like this, I would tell you that you're crazy. However, seeing how everything works, the positive results, I think Mr. Johnson can even elaborate on how many people wind up in the system that really don't need to be there. And I think this is a really good avenue to off-ramp a lot of those folks to get them the care that they need through not the criminal justice system, but through the healthcare district and our partners that are working together on this. It has shown proven results. And the numbers don't lie right now. And I think as we move forward, we'll be able to present this to the sheriff and actually build this program even to a larger extent so that we're reaching all the communities, and it's not just during the day. We can cover more ground and hours.
Thank you, Lieutenant. And I agree. And we're humble. We're learning from this. There's a lot of avenues in this data set, if you look at it, that we can improve. There's efficiencies that probably can happen here, but it's a really good start. And it's enough to show that we have to keep working at this and get it optimized over the next many years. So I look forward to continuing the partnership. Just to finalize kind of COAST is our law enforcement programs. This is the pilot where people get dropped off at the clinic by law enforcement. So the officers bring them actually over, and we have almost actually all the municipalities and now the unincorporated PBSO officers on this side of the house. And this is occurring in a clinic where we also have a lot of other clinical things going on. So in this one, you see, we've seen 165 patients, 19% were existing patients. Again, this is somebody who might be disrupting a business on Clematis Street or just walking around in the middle of traffic, and somebody says, we've got to stop with them. Interesting difference with the CRT group. 70% male, not 50-50, and 56% homeless. So markedly more homelessness when an officer is bringing them to our clinic than when they're calling 911. Still almost the same amount of insured patients in this side. And you also see the different types of providers bringing them and how we're building in that way. Totally, we've had 61 officers. We do see it's a big commitment for an officer to bring someone up there, especially if they live there or their municipalities further away from the north end of the county. But these are the dispatch call types you see mostly are mental health related. A large percentage of them stay in the clinic. And not that many have been Baker acted, actually. So we're trying again here to prevent Baker Act and start treatment in the clinic, as well as to start to hook them into maybe longer term services. I'm very honest about this one. This is the hard one. This is the harder one for us to get patients back for their appointment. So if you see patients coming back, this is where we're struggling. I've identified that this is where I think case management, I'm glad DCF is bringing up their new system.
She's very honest about this one. Does that?
Hey, Ariana, did you have a question?
No, I'm good. I'll text you privately. Sorry.
That's okay. But coming back to see a provider is hard. It's very hard to find these patients. Many of them don't have phones. Calling doesn't work. This really highlights to me just the need for so much case management. And speaking of Ariana and what she just said, I mean, people who find these patients in an outreach function are really important in the system. And we continue to use this to start to brainstorm and look at the literature for better ways to get these patients back to us to keep them in that lower level of care. But this is a challenging one. Most of the most of the patients have 2 to 3 things going on at once, and most of them are actually substance related, psychosis or mood. If you categorize these into the 3 biggest kind of clusters of what's happening, and alcohol is still really a big problem in this group of patients as well. So engaging them is important, but you have to be able to provide mental health and substance use care. And that is what I have for today. I just wanted to, this is a video if anybody's interested in watching, but I wanted to pause here to see if there's any comments or questions.
I'd like to hear from Ariana. She's boots on the ground in Delray and South County. How do you see this program going, and has it helped you at all?
Well, because we're in South County, Dr. Phillips and I had met a couple of times because I would love to see this happen down here. It's just that having an officer drive up to 45th Street is really difficult.
Right.
What I was going to say before when I interrupted so rudely, and I apologize,
Okay.
is that I would love to see, like, I know when the clinic is done and we're down here, but I really would love to implement that part of this program down here because it's really needed. There needs to be somewhere where we could bring someone that they're having an episode that they don't need to be Baker acted to go meet with someone hands-on at that moment. And we just don't have that opportunity down here.
Well, Ariana, I think our clinic can serve, you can start using that as a pilot during regular hours, because during regular hours, 8 to 5, we have full-time psychiatrist, psychiatric nurse, and licensed social workers in our Delray clinic. We opened that 2 years ago, but we didn't see a lot of volumes. So I think start tomorrow, start today.
Right. But we'd have to have something in writing. We need an MOU. We need something that we can work together because we have to give the officers the buy-in. That's the thing. I can say it all day long, but if we have some sort of
let's do it. Like we'll send our team a similar way how we did with other municipalities. But I just want to emphasize that we have similar access to care, the same care that they receive in Mongonia, they have in Delray Beach. And the reason I'm like a little bit kind of jumping on this topic is that clinic in Delray is very underutilized, and we have resources, but we created videos, we did the press conferences. We have to start utilizing those services, otherwise we're going to lose them.
Right. Okay. All right. So we'll talk after the meeting.
Ariana, so Max did approach Chief of Delray, the new Chief of Delray, and I think there's discussions about an MOU, and we could possibly adapt it a little bit for South. We don't have the meds in the clinic right now, but I think Dr. Hendrick, that's an operational thing we could work towards in a manual way.
Oh, okay. That's the first I'm hearing about Max reaching out to Chief Hunter. So I'll get with him. Thank you.
And however we can help from the law enforcement aspect, please, by all means, reach out. I have no problem making contact or even meeting with the chiefs down there. I know Captain Foley is also involved with that as well.
Okay, great. Thanks.
This is a good segue to the broader law enforcement community. I actually was working a case with some PBSO detectives who had never heard of the crisis response unit. And we were dealing with a homeless person who was also drug addicted. who we were trying to get to 45th Street. And Dr. Phillips, I had called you
Mhm.
on that particular day, and unfortunately we weren't able to connect with the mobile unit. But this is something during the uh, investigation of a case, if there are homeless or drug addicted people or people in crisis, to get them into treatment means that we'll have a stable witness going forward, especially on violence against persons crimes. I'm not talking about like a trespass, but when you get some of the upper level, it's critical for us. And many times when it's a street crime, we are unable to get a witness who's sober to come in for a deposition or for trial or even to show up. So I think that's something moving forward, that getting the word out that we're not all in our silos going forward, but law enforcement in all the different agencies can utilize this in helping a witness or a victim. So just want to put it out there. Any other hands? Any other questions or comments? Okay. Thank you so much, Dr. Phillips. Appreciate
Thank
it.
you. Thanks for having
Lieutenant
us.
Pizzino, thank you for coming. And this is great stuff. I think it will only grow because the problem's there. It's just a matter of getting the resources out to the people. So excellent. Let's move on to we have until 2 o'clock when DCF will be coming on board to do their new database, their new system, and their new website access. So I'm going to do some snapshots. Hey, good news. I mean, great news would be zero, but if you were following these statistics in Palm Beach County, you knew that we had approximately a 40% decline in last year, 2024, in opioid overdose deaths. And this year, we're looking so far at another 40% or so decline. We're seeing numbers that we haven't seen in over a decade. For a brief period in between the pill crisis and the heroin / then fentanyl crisis, which peaked at 647 deaths in 2017 in Palm Beach County, there was a lull, and I think in 15 there were 287. We're at 88. If you look at the second set of data, we're looking at 25, January 1st through September 12th. Now, there are 19 pending cases, so that kind of skews the numbers. But last year at this time, if you look at the first set of data, we had 270 overdose cases, 195 of which were opioid OD deaths. And fentanyl was 90% of that. This year, we're at 88. It's astounding. We haven't seen these numbers, as I said, in well over a decade in terms of opioid overdose deaths. So this is really encouraging. Fentanyl is down to 83. And so we're looking forward to seeing these numbers continue. I'm going to ask Ariana again, because you're our canary in the coal mine in Delray, which is the epicenter, or was the epicenter, of the opioid overdose crisis. So what are you seeing in Delray now this year?
Our numbers are half of what they were last year, and last year they were very low.
Yeah, this is wonderful news. I asked the medical examiner whether there was some other drug like cocaine that was spiking, and the answer was no. And if you all following the news, there was this article out about Miami-Dade, where ketamine was exploding in Miami-Dade in terms of causing death. And so I asked the medical examiner, and we've only had one this year so far, almost the first 3/4 of the year. We had 0 last year, so it's not in Palm Beach County ketamine anyway. We're reduced in carfentanil, and fluorofentanil is basically, that looks like a 80% decrease right there. Hey, these are encouraging. And of course, with regard to fire rescue, if you go to the next slide, we're continuing our trend downward in terms of suspected drug overdose calls. And you see where we peaked in 2017 at 2007. So far this year, in the first it says June 30th. Didn't change that. It should be August 31st. So through August 31st, we're down to 513, and that's not a 6 month, but it's a 7 month. Again, that didn't change that, but we're down 74% from 2017 in terms of a reduction in transports. Very, very encouraging numbers. We're not done. I mean, we still get calls on the hotline for bad actors in the county, and we're still reviewing those and sending them to agencies when we find that there may be criminality. But the crisis has certainly decreased in Palm Beach County. Any questions on this or any comments? Okay, thank you. Let's move on to FAR. Michael Schlossman, let's get an update from FAR.
Thanks, Al. I'm going to turn it over to Josh Thrasher, our Deputy Executive Director.
Thanks, Michael. Thanks, Al. Are we sharing the screen, or do you just want me to go through the numbers real quick? Because I have
let's share. If we can share, if you want us to put it on there, we'll do it.
Sure.
All right, let's do it. If we can find it. Hold on. Oh, by the way, I'll make this announcement. We have a lot of members from the public, and I always forget to say that at the end of the meeting, if anybody wants to make a comment, I'm going to open it up. So, if you're here and you have something burning, a hole in your agenda to mention in the task force meeting, I'll let you do that at the end of the meeting. Okay, there it is.
Yeah. Thank you, Al. So as of September 2025, we have 280 providers certified across the state of Florida, 9,775 beds. So I know we're trying to get to the 10,000, and I just wanted to give you some insight on that. So the last month or so, we have suspended a 159 bed provider, revoked a 47 bed provider, and then we had two closures, 127 beds and an 80 bed. So the good news is that we are certifying our programs in a rapid pace now. So just September alone this month, we certified 8 providers for 193 beds. So we're keep digging out, and we'll be at that 10,000 pretty soon. But I know you've had some questions about that. So we have contraction in addition each month, but we've had some unusual large providers close and a few suspensions, but we hope to have them added back as a provider soon.
Yeah, and with regard to that, Josh, it's not 10,000 is a magic number just for visuals.
I get it. Yeah.
But the fact that you have been able to maintain, because it's very important that FAR not just be, a licensing or certification entity that just doles it out.
Absolutely.
And the fact that, that you've had to take action against some providers. And again, they have their due process if they, if they feel you're wrong. But those providers who are not living up to the requirements of the standards, you have to do what you have to do. Otherwise, there's no benefit to FAR. So I congratulate you on your diligence.
Yeah.
And can I scroll down? Yeah. Okay. Oh, there we go. Okay. Now I did note, and I don't want to take away your thunder. I don't know if you were going to mention this, but it does appear that you're getting other counties involved in this process, because I can see that Broward and Palm Beach County, as an overall percentage, is somewhat reduced. I remember when we used to be 77% of all in the state of Florida. So can you comment on that? Or
I can. So out of those 8 programs that's been certified so far this month, 3 of those have been in the central region, like Orlando, the greater Orlando area. So Suncoast is growing as well. We still don't have a whole lot of growth in the southern region. I mean, we have probably about 13 providers total in southern, but central is growing.
When you say southern, you mean Miami-Dade?
Yeah, Miami-Dade, Monroe, that's the southern region.
Okay.
Yeah.
Do you have any thoughts as to why that is? I mean, you have 3.5 million people in
I,
Miami-Dade. That's as many as Broward and Palm Beach County combined almost.
So I don't. I believe part of it is just us getting into the space. So we have regional coordinators throughout the state. So our statewide regional coordinator, she went to there's a Miami-Dade Behavioral Health Alliance, one of those meetings that where a lot of these folks get together. And so I think that's our first step is just to get in there and start knowing some of the players and just being a presence in that community is really huge. And I think that's what's led to some growth in the central also, and southern, because we have regional coordinators around the state now that's really knowing what's going on. They can identify needs in the communities, and they have someone to talk to. So our certified providers definitely love having their own regional coordinator, just someone that they can reach out to at any time. I believe that's created a lot of goodwill for FAR. So we're looking to do that in Southern as well.
Okay, so I sorry to interrupt, but go ahead down your numbers and
Okay.
let us know what.
Yeah, so Palm Beach County, I'll drill down on those numbers really quick. We have 104 certified providers. Total beds is 3647, 3,647. Men, it's 1,831. Women, 601. Serving both genders is 1,189. And then there's 26 LGBTQ beds. So the levels of support, we have 6 beds level 1, 1,672 beds at level 2, 64 beds at level 3, and 1,905 beds at level 4. So that's really it, Al. That's all I have. Yeah, there's the rest of the counties. You all can peruse that if you so wish.
Well, I mean, you see any other than the three this month in Central, in Orange County, do you see any growth in any parts of the state that you want to mention?
There's been a little bit in Volusia as well. Volusia County, that would be technically the Northeast region, very southern end of the Northeast region. But mainly in Central, Suncoast, there's some growth as well. And obviously, there's still growth in Broward County and Palm Beach County. There's still growth, but we may have some of those other regions maybe outpacing it slightly. And I believe what skews those numbers also is some of the providers that may have closed or that may be under a suspension right now is in the Southeast region.
Okay. All right. Any questions on?
I just had 2 quick follow-ups, and thanks, Josh. That was great. So Al, a lot of what we're doing around the state, as you know, is planting seeds that need some time to grow, especially with stakeholders, both at the political level and the local level, municipalities, working with them on implementing SB 954, talking about other zoning issues, and those are all starting to pay dividends. So sometimes we don't see it immediately in an uptick in bed count, but it's seeds that are growing for the future. The other thing I want to mention is Josh, myself, and Susan literally just got off the plane from the NAR Summit in Ohio. And we're so excited that the NAR Summit is going to be here next year. Right now, it looks like it's going to be September in Fort Lauderdale. And we'll let everybody know about that. But that's going to be a great opportunity for our state to shine because we are the largest non-mandatory affiliate in all of NAR.
You may not know the answer to this, but I've always been curious. What's the next highest number of beds in any state in the United States, if you know?
I think Josh,
Yeah.
go ahead.
So Al, Ohio made certification mandatory, and now they outpace us by about 400 beds. Now they're mandatory, we're voluntary, and they beat us by about 400 beds right now.
Well, interesting, because if we'll discuss Chapter 419 and the
Mhm.
legislation we're proposing, and as a quid pro quo, I'll call it that because I'm a lawyer, but of permitted use instead of reasonable accommodation. So you can really walk in without having to go through the tortures of going through the process of getting an exemption. But in regard to that, you get a recovery residence has a permitted use within a very short distance spacing, but they also must be certified.
Right.
So
Mhm.
it's not making it, well, it's sort of making it mandatory, but in a way that benefits both the providers and the communities. And that should be have an impact if it does pass on the number of certified houses around the state, or programs, I should say. Okay, any other hands or questions? Okay, let's move on. I think we have a couple of minutes before the department will start their demonstration. So let's go ahead and do Oxford House. Michael, are you going to share? You want us to put it up on the screen, or you want to share yourself?
I can share it. Thank
Okay,
you, Al.
sounds good. Thank you.
Yeah, so I just want to say that Miami's been difficult for us too, and I'd say it mainly revolves around the cost of just housing. It's just so expensive to get in a good neighborhood down there, and so it's something we've been battling. So yeah, across the state, we have 272 houses now at the end of August. Those are our numbers, with 2,425 beds, 161 men's houses, 49 women's houses, and then 56 women and children's houses, and now 6 men and children's houses. We did have one overdose since our last meeting that was a fatality, and current MOUD stats at the end of August, 69% of Oxford houses in Florida had at least one member using medications for opioid use disorder, and 18.5% of our members across the state are on medications for opioid use disorder. Over the next 30 days or so, we're going to be opening, as long as everything goes according to plan, 8 new Oxford houses. Pretty excited. We have 3 new cities that do not currently have any recovery housing that I'm aware of, in Palatka, Destin, and Claremont. And then this Palatka area is an entirely new county for us, so it's Putnam County. That's pretty cool. And then Destin's Okaloosa County and Lake County. So we're really focused on continuing to open houses in the most needed areas, Miami-Dade, all other places across the state. But then in more rural areas, want to continue to try to get into those as time goes on. We just had our World Convention, sent 184 of our members from across the state to experience some really good speakers and panelists. It was a really good time. People learned a lot. Big thing that we have going is our Reentry Association. We're having a lot of success with getting individuals directly out of incarceration. We're averaging about 65 members per month coming out. I've attached an impact report. Please feel free to check it out. There's some really good information in there. And there's about a dozen personal stories of this individual's recovery in Oxford House. Some really cool stuff to see and really good life experiences. That's all I have, Al.
Okay, thank you, Michael. Any questions? Any thoughts? I'd like to pivot back to FAR for just a minute and ask Josh or Michael a question. How's the MAT educational program going? Is it expanding? Are you getting people to agree to the MAT programs that you're requiring?
Yes, we are, Al. So it's going better than expected. We didn't anticipate like really like major pushback, other, maybe a few programs here and there. We felt like everybody would comply, and that for the most part has happened. So all providers now are required to have a medication assisted treatment storage and usage policy that's part of their renewal going forward. We spread the word on our regional meetings throughout the state. We had one provider in the Suncoast region that did not renew because of this, but they were getting ready to retire anyway, so they just kind of took an early retirement. So, but everyone else is on board, so it's went really well.
Great, good to hear.
Mhm.
Okay, we're through our updates, and I don't know if Martha, you're on? Okay. Oh, there you are. Okay, so I will turn it over then to the department. And I'm very excited. We're going to get a demonstration of the new database and the new website, which I believe is scheduled to be in the public domain in October or so.
Getting close. Good afternoon. I'm Martha Harbin. I'm an assistant secretary here at DCF. I am over the Office of Quality and Innovation, which is the office that houses licensing at DCF. And I'm excited to have this opportunity to share this work that we've been doing. Our goal is to better serve the public, better serve providers, clients, and their families through modernizing our substance use disorder provider licensing platform. In its current form, you all may know it as PLADS. And the new system that we'll be showing you some of today will increase transparency and functionality and really step up our licensing technology game here. So with me on the call today is Cole Sousa, who's DCF's Chief Information Officer, and Tammy Jackson. She's the project manager on this technology build, and she'll be walking you through some of the features. Before we get started, I want to take an opportunity to just express our thanks to Al and Senator Gail Harrell. I don't see that she's on the call, but and everyone who's contributed to the feedback that we've received, and especially for the tireless advocacy that Al and the senator have driven, to drive quality services and to help, get these kinds of outcomes. They've been real champions in Tallahassee. Today, we're going to cover two separate but interconnected topics. One is a brief overview of some enhancements that we've already made to the SUD licensing dashboard on the DCF website. That's a BI, that's what I'm looking for, BI dashboard that's powered by PLADS. Some of you all may already have used and experienced it, and I'll drop a link to it in the chat. And then a preview of the new functionality that will be gained when we launch the new platform that's currently in user acceptance testing stage. So we're working through bugs. We have some providers lined up who participate in the user acceptance training once it gets kind of through the internal process for that. And, and then we'll commence the training and onboarding activities. So first on the dashboard, the existing dashboard, we formerly had two different dashboards. One showed provider license information, and the other showed inspection and administrative order information. And that was difficult to navigate. It was organized by service location name rather than, by provider. It was not consolidated underneath the providers. And a lot of the complaint insights that you might want was kind of buried within the inspection reports. You had to open up each one as a PDF to kind of see if that inspection was done as a result of a complaint or if that was part of just the normal annual relicensing or initial licensing process. So in the short term, our IT team combined those two dashboards. They place the inspection information within the same view as the other licensing information and improve some of that navigation. We default now to only active licenses because previously it had defaulted to the entire database, and that was confusing from some folks who weren't used to the filtering functionality on a BI dashboard. So now it defaults only to active licenses. And And then we did some other enhancements to our website to make sure we had lots of cross links between our substance abuse and mental health section of our website and our licensing section of our website, so that it felt very seamless to a user who was maybe uninitiated for the way DCF is organized. But much more exciting are the changes that are coming in our new platform. And these will include improved search capabilities, simpler navigation, more streamlined data entry for providers seeking new licenses or renewing existing licenses or submitting corrective action plans. And for the public, a very simple online portal for submitting complaints and more visibility into the outcome of complaints submitted that trigger licensing inspections. As I said, we're in UAT of the new platform. We will be, in fact, I think an email is dropping to providers today telling them that, change is coming, and make sure you have current licensing contact information, because that's how we're going to be inviting you to trainings and that sort of thing. We'll be creating user videos and having those online so that people can self-help themselves. So that's all in process. And so with that, I'm going to invite Cole Sousa to step up. I'll go off camera and mute myself, and I'll turn it over to Cole and his team to preview some things for you.
All right. Thanks, Martha. Okay, so as Martha stated, we are going to do a demo here on the system. What I am going to do is turn it over to Tammy here in just a second. We'll just quickly bring up the current dashboard that's on the website right now, so that you guys can get a view on that if you haven't seen it yet. And we'll just touch on a few things on what Martha had mentioned on some of the enhancements we've made. And that's out there currently. But what we will do, though, is the main focus will be is to bring up what we've been working on to modernize our current plat system and streamline the overall system itself to make this easier, better, faster to process licenses and give a better experience to our workforce and our users who use the system. So with that, I am going to turn it over to Tammy, and she will lead the demo. I might periodically jump in with a couple of comments. But other than that, Tammy, go ahead and take it away.
Tammy, don't forget to unmute yourself.
I just saw it. Thank you.
Okay.
Can everyone see my screen okay?
Yes.
Okay.
Yep.
So this is the existing dashboard that we have, as Martha had mentioned before, where we have a tab for our provider information, which will get you to your any of your administrative action letters, right? And then the inspections tab here that will get you to your inspections broken down by the provider site and their address information, right? So that is what we currently have today. What we're going to be going to will be an updated screen. I'm going to switch this over.
And while Tammy's doing that, one thing I just want to clarify, what we're moving towards, though, is a much more robust front-facing portal that will be on the website. So currently what we have now is a dashboard. We've made some enhancements to that, but we'll be moving away from a dashboard, and this will be an actual web application that will be embedded into the website that the public can use to find information.
So I will mention, can everybody see the provider substance use disorder licensing and designation search screen?
Yes.
Okay, so this right here is connected to our UAT environment. So we do have UAT data in here. But I did want to be able to show you at least what it looks like as far as when you drill down. So you can actually search here by your provider names. Right, it'll go ahead and drill it down to your provider names. If you want to actually, like with Blue Serenity here, you can see that we have 2 sites. We can view those 2 specific sites. This was a test one here, so I just wanted to see what it would look like if I didn't enter any information. So that's the reason why you see nothing here. But as you drill down in the provider profile, we can see all of the buildings and their components, and whether they have their active components And we can drill further down. We can also see if they have any psychiatric services also within these buildings. All right. And then as we drill further down or roll further down, we can actually see the corporate information. Now, if we drill down into a building here, we can actually zero right in on the address. We have a heat map here. All right. We also have information about the service components themselves. So target population, we end up having how many, clients can they serve in any given day, the hours of operations, those special population groups that are targeted for services, and whether they are accept some public funding or private funding. All right. And then you break it down by each one of the components here. We will also have information about your recovery residents, your complaints, any administrative actions, the inspections reports, and your policy procedures, and the applications from when they're actually applying for components or facility types. So this is a new one, so there isn't a whole lot in here right now. So we have our recovery residents.
If I may,
Yes.
that would only be level 4, which are the level is the recovery residence day night with housing that you do license, or is it all recovery residences?
So,
and here's a little context as to why I'm asking a question. I know on your licensing that that a provider is required to list the recovery residences that they have a relationship with. It's not only level 4, but it's any recovery residence. And I was wondering whether the new website will people will be able to find out which the location and which what named recovery residence is of all levels that a provider has a relationship with, or refers or accept referrals. And if you don't know that, you can call me back later and let me know.
I will let you know.
Okay, that is important, and this is an ongoing process, and it's great that you have that. One of the issues that we've had over the years is to be able to see, which recovery residences are have a relationship with which providers. It's very important for people to know that when they're trying to place their loved one into a treatment facility.
So yeah, we'll definitely get you that information.
And I guess the collateral thing, and Michael might have brought this up, Schlossman, in order to know which recovery residences are certified, because anybody who refers or accept referrals, any recovery residence must be certified. That information is critical to prevent uncertified recovery residences from referring and accepting referrals, which is illegal. Make sense?
Yes, sir.
Okay, thank you. And Terry, I'm going to allow you to ask your question, but I do want to let them. I broke my own rule, which is wait until the presentation is over. But since you already have your hand up, and then anybody else at the end of the demonstration. Terry, you need to unmute yourself, sir. Terry, unmute. Okay. There.
I was just going to say I can wait to the end, Al.
Okay, good. Thank you. Thank
no
you.
worries.
All right, Ms. Anderson, go ahead. Thank you.
And just so you know, we are going to update this where we'll have a grid inside, but we'll also indicate if there's any documents, how many documents that you have, so that you're not having to go into something and not find anything. All right. So we're going to update that. Okay.
Tim, do you want to just touch on the recovery log there, though? I know she pulled that up. Do you want to just pull that up real quick? Okay. Oh, that's what you showed earlier. Okay. Gotcha.
Yes. Yes. Yeah. So, yeah, 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 so, yeah Mr. Johnson had a couple more questions surrounding this one.
No, actually, I'm good. We can talk offline later.
Mhm.
Just want to make sure we're on the same page with, it's not just level 4, but it needs to be any referral relationship with the recovery residents by law needs to be in plats. So,
Right. And I think that's the way that this is set up, is that any referrals that you have, what the referral, or if you're actually referring a person to a residence, it has to be indicated on here. And this is actually set up where they can actually enter their information. This one's been saved, but they have this on the main SAMH licensing webpage. So they actually have drop downs that you can actually enter this information, whether that location is a certified location or non-certified location. Okay. I'm going to go back home. The other thing I wanted to show you about the provider search is that we have other filters that you can actually search by. So you can actually search by specific provider. You can actually go by the city. You can actually go by the type of license, right? So if I say I want to look at all that are in probationary license status right now, it'll show me everything that's in a probationary status, right? So you can look at this many different ways. Any questions, or I'll move on to the next thing here.
Terry, you have your hand raised. You go ahead.
Yeah, this is great stuff, you guys. Thank you very much. It's really definitely advanced and very robust system. Just wondering, at any time, is it going to tie in nationally to the SAMHSA treatment locator in any way? Are you able to do that? That was question number one. And number two was, Al, kind of a question for you. When you're using the terminology, they have to show the relationship with the recovery residents. You're talking about that they have a direct business relationship. For example, Hanley Foundation has their own housing, and you have to, maybe it has the same name, but they call it HCC or something. That's where you want to be able to see that here in the system, or you're talking about some other form of relationship that may be informal.
Well, any referral or acceptance of a referral. So either way, getting a referral from a recovery residence or making a referral to a recovery residence, the provider is required by law to make sure that that residence is certified. And
Right.
so it's not necessarily a contractual relationship. It could
Right.
be just an
Right.
informal referral relationship. They're supposed to enter that into plaids.
Okay.
So
Yeah,
that
that's right.
everybody knows who's referring, who's accepting referrals.
Yeah, got it. Yeah.
Okay. And your second part of your question, I guess, Ms. Anderson, is it ever going to tie into the national SAMHSA database?
So with that one, I can check back with the licensing team to see if that's one of the goals that they have. But if that's what they want to do, we definitely can look at doing that.
Yeah, because if I go into the SAMHSA treatment locator now and I start looking at state of Florida, I'm going to get pretty limited information that treatment centers enter, if they even wind up doing it, into the national database. Whereas what you have here is phenomenal, and that's going to give everybody and anybody nationally the whole state of Florida and all this fantastic information. So there's got to be a way to do this, I would think.
And to
Thank
tie
you.
that up, we have so many patients coming to Florida for behavioral health treatment.
Exactly. Yeah.
That somebody from Ohio will never be able to utilize this unless it's in the SAMHSA. Well,
Exactly.
I suppose they could if they knew to go to DCF.
Yeah.
Department,
They won't know.
but
They won't
most
know.
people just go to the SAMHSA and look around. So that's a great point, Terry. Thank you. Michael, you had your hand up?
Yes, thank you, Al. Going back to that form you had for the recovery residences, where it says certified or not certified. Yes. In the case of Oxford House, because it's not technically certified and it is chartered, but still legally be able to refer to without any issue, is there something that can be done to indicate that, or can it be directed that they would put certified so they don't think that they're getting in trouble? Because I know that we've had issues in the past. Uto, when she was with the department, put out a memo really explaining that people can refer to Oxford House. We might need to do that again and more education on that. But I think that this part might be a little confusing for the case of Oxford House.
Perhaps you can just add certified or chartered. Maybe that would do it. Because we only have two kinds at this time in our history. While there may be a third sometime down the road, right now it's either chartered or certified Oxford House or FAR certified. So, okay, thank you. Please do go on. I think don't have any more hands raised right now.
Okay, no problem. Okay, so one of the things I wanted to show you, we talked about the complaints portal, right? So we're going to have a link out there on the SAMH licensing webpage. Right now, I have it tied in for testing onto our SAMH licensing, but I wanted to show you what that complaint page looked like. So on this complaint page, pretty much everything is going to be optional. We do provide them a list of all the providers, right, that are in the system. That if they know the provider name, they can actually select the provider. If they don't, or they know the provider by another name, they can always enter that provider name here, right? The only required fields that we're going to have is that we need the county, right? Because if we don't have anything good as far as the provider, at least with the county, we can send it off to the regional office and let them start their research, right? So the county is going to be one required field, and the other required field is going to be the complaint description. Okay. From the internal side of the system, if there's a complaint that comes in via email, by phone, or in person, the staff can actually create a complaint internally, right? And then they will actually be able to indicate how did that complaint come in. Okay, so I'm just going to do a real quick one. I'm actually just going to indicate break provider. Right. I'm going to say that this is going to be that super site. This one actually is in Clay County. Right. The only other thing that they would need to do is indicate what the issue is. I could type. If they have any documentation, they can upload if they choose. Right. And then they just need to acknowledge the document. Once they submit it, they'll get a complaint ID. And this will follow through the system. Okay. The other thing, any questions about that? It's a very simple one. The biggest thing is that, we got to have that counting. Okay. The next thing I wanted to talk about was actually the self-registration process. So we've made this a very simplified way that if you're actually starting a new provider or you have a user who is coming into an existing provider, that they can actually come through here. This is one of two ways that they can get their accounts. So if we're going to create a new account, it's a very simple form, first name, last name, the email addresses. If I say I'm going to create a new provider, you enter the provider information, and then you're going to select your role that you're coming in. The biggest thing is that the CEO is the one who can sign an application, right? We're going to be adding designee, also CEO designee and an owner designee to this. Okay. The other thing I wanted to show you is I'm going to move into a provider screen. We currently use Okta as our authentication, right? And then from inside the system, we have our security on the roles. Okay. When you log in, you can actually see what role you have. Right. And since I am the CEO of Blue Serenity, right? I can actually see my 2 sites, and I can currently see all of the applications that I have right now. All right. If there's been any corrective plans that have been created, I'll see that also down here. All right. I'm actually going to show you what an application looks like real quick. So application is going to be very streamlined, and it'll look very similar to what the paper application looks like. So we'll have it broken down by our providers. You'll enter your employees, right? And then you'll enter your sites. So we'll have a concept of multiple buildings within a site, right? Like a compound, right? So you can add as many sites as you want, or sorry, as many buildings as you want to a site. I'm in designation. So here I will have my what type of facility types that I've actually chosen, right? So with this one, it was only adult crisis stabilization. And then you'll also have your documents, so all the documents that you are required to upload. Some of these may not be specific to you, so everything is left open so that when you go to submit, it's not going to stop you, right? If there's anything that you need that's still needed, that will be handled between the provider and the AA, the authorized agent. And since this one was already signed and submitted, we got our declarations and our signature. And then the admin review, which I'll show you that from the main screen. I think the one thing I wanted to show you was really a provider one, SUD one. Let's see. Yeah. It will, and when you create one application, like if you create an initial designation application and you need to create an SUD application, it will pull that information in automatically, your provider information, your employee information, and your sites, right? And then you can go ahead and continue filling on in. Any questions before I move forward to what it looks like on the internal side?
Yeah, Ms. Anderson, just want to clarify. What you've just shown us is the internal, if you're starting a license process. In other words, you're
Yes.
trying to obtain a license.
Mm-hmm.
Is there, I would imagine that that's not at that point public record because it's in process until it's done and
Right.
completed.
Mm-hmm.
So do you have a a database easily, if you're looking, for example, somebody's looking for several documents from a provider who is already in existence, do you have the same system that's public record that people can just go to the website instead of making a public records request to the department, can find the documents they're looking for, the application documents?
So the application documents like a copy of the application will show on the provider search screen, right? So they'll be able to pull that without any issue, right? Same thing with like your policies and procedures.
Okay.
Mm-hmm.
All right, thank
And
you.
that's, Tammy, that's what we demoed earlier, right? Previously.
Yes.
Yeah.
Okay. So I wanted to show you what it looks like from an internal screen. Did anyone have any questions about this area right now?
Yeah, just one question. So that's the internal screen, but
No, this is external. This is external.
the one that you showed previously with the policies and
No, that was the public.
so public can see policies and licensures and all of that.
Right. So they can see that one. We had any of the the inspections. They had the policies and procedures, the application. They had any complaints that were founded, right? And then they also have any. There was one other one that was on there.
Okay,
But that's the publicly accessible one.
Gotcha. Thank you.
Mm-hmm. Okay. So right now I am in as a system administrator, and then I also have an additional role as a regional manager licensure specialist. So this allows me to actually create paper applications also. All right. So this is what they will look at when they first come in. They can actually see all of the applications that they have, any corrective, any inspections that they actually have in progress and things like that. They can actually see those. The inspections tool has really been modernized. To allow them to actually see how many questions are within a specific section and how many are actually complete, right? So they haven't done the client record yet, all right? So it's a very modernized piece here. I want to see if I can find another one. Leslie's always pretty good about hers. I feel like I keep coming back to the same thing, all right? But they can see all of their questions. This is actually set to be very responsive and it scales down. So if they're actually coming to inspect a site, they can actually have tablets to do this with. Right. Their corrective action plans, they've got everything that they need up here. And then here's that complaints site. So here are complaints that we have. So this is the one that I did earlier. Right. And with their administrative section, if they find anything it's being substantiated, they've got their report, right, which is the complaint, the background, the findings. There's actually going to be a document that will end up going on to the website if it's founded to actually show all the same information. They can look at any payments and invoices that are out there. Search by anything specific. They can actually view these invoices. Anybody have any questions about anything so far? I know this was just a small overview of what the system looks like, but it definitely has been modernized. And from what I'm hearing from the testers, it's been flowing pretty easily. And even they said that going through the application, once they stopped overthinking it, it went really smoothly.
You know, I'm going to ask Susan Ramsey, who has probably the most experience in trying to navigate the database and the previous website, to chime in here for her, you know, her thoughts, if that's okay.
It's okay with me, Al. Thank you. And I see this as an improvement, but it's still a little not as user friendly as I would like it. It has a little more information. I mean, because I have spent a lot of time on your website, and because you know it is a wonderful resource to figure out for those who want to know what the levels and what licenses a particular facility has. And I'm glad that's a big improvement. You know, alphabetically or by region is you know, alphabetically does make sense if, of course, if you know, and you also have like real names of people in there, which is, I think, a real improvement. So you can contact people and have, you know, the consumer can call the administrator of whatever place that is and say, you know, I have concerns, whatever, because that's really one of the bigger issues, is especially for family members, is how to communicate appropriately and who to contact if they have concerns above and beyond whatever the clinical stuff is. So that's really great. And, I'm not, since I haven't used it yet, I don't know, the ease of transitioning through these things, that's the part I don't have a feel for. Because that's also a little confusing on the original website, but I am very optimistic about this. So, yeah, because I do use it a lot.
Well, that is good to hear. We set this up to look very similar or have kind of a similar feel to the way that ACA's facility finder is.
Right. That's another one I look at a lot too.
So that's what we use as a basis for this system. All right. To give you that drill down look.
Right. I mean, it really is. It's a market improvement. It really is.
Okay,
So
thank you.
once you launch it. So you want feedback once you launch it with, anybody here?
Sure. Yes.
Okay, good, because we can, I certainly will give you mine, having used these things for years. And I know other people on the task force also use it as a resource. I mean, FAR certainly does. And, I imagine other individuals do as well. And then we should talk about the connection between the FAR website and this website, because I think might be an easier way to do it. Because we do FAR has lists of certified providers and what levels they are, and, by county and name and all that as well. So that could be a way just to connect the two together. See if that made any sense.
It does, because I know in our application, we also have like the accreditations, right? So what is each provider, what kind of type of accreditations they have. So even having something like that on the website might be beneficial also.
Yeah, I mean, just a link to the FAR website.
Yeah.
Right. And then people can go from one to another, depending on what they are seeking in terms of services and where they are located. Because again, it's a big state.
And if I may, one of our goals on the licensing side is to modernize the platform that our licensing specialists and our licensing processes are using to do their jobs. So, this ability to be able to do your inspections on a tablet, and we're not scanning in PDF documents and, that sort of thing. Some of the functionality that I'm hearing, like the connecting with SAMH, or, having some overlap with FAR, I think that that's definitely things that we can, be looking at, and can be, taking that feedback and seeing, what we can do to drive that. But I did want to kind of manage the short-term expectations. It's really to bring the whole licensing function forward into more of an automated, more of a digital kind of process, thereby making the ability to search for the information that we collect and can publicly disclose that much easier to find. Because we're in an environment now where it's literally scanned in, PDFs of handwritten pages, and it doesn't make for searching or parsing data very, very easily. So that's our short term, that's our goal for the platform. But then I think we totally can be iterative over time, looking at the ways that we can create connectivity, the way that we can help seamlessly assist people in maybe moving from licensing information to something that's more consumer facing information or client facing information or something like that might live somewhere else. So so I'm excited about the potential, and our commitment is to continue to work to do what we can to increase that connectivity and that visibility.
Well, this is great. Thank you so much. I am going to ask one question, because I know Senator Harrell would have been here today, but she's on an airplane. Can't do it from there. But she was interested, and I know this is a difficult subject matter, and I don't know to the extent that ACA does this, but some kind of a star system or some kind of a designation that can show certain providers are meeting standards, kind of a level. And I don't, it's hard. How can you pick and choose as a department? If they have a license, they don't have a license. You can say whether they're accredited by one of the accrediting agencies, entities, or their houses are FAR certified. But other than that, I don't know if you've given any thought to that, but I know she would have asked that question about how does a consumer from North Florida who wants to go to South Florida, or from Ohio who wants to go to a treatment facility, be able to, go through the hundreds, if not thousands, of choices.
Yeah, we're aware that that's a desire to get to. We currently don't have the statutory permission or ability to have something like that. I think if you see there's a nursing home ranking system in the state of Florida that's specifically, created in statute for directing the agency to create that. But we are looking at, well, within what we can do, what are some, possibilities? I don't want to throw anything out there and create like an expectation, because some of it, we have to just see like, well, can we do this? Can we do that? We have to run it through a lot of traps. But, we're trying to see like what is within our purview to be able to do, to be able to be responsive for that to Senator Harrell, to make it very clear, kind of like what we're empowered to do and what would take additional statutory permissions to do.
And because she's a senator, she'd be very keen on, okay, what language, what change in 397 needs to be made so that people trying to find a facility for for their loved one, can have some kind of guidance. So maybe that's right. Maybe that would be, the key would be to do it in a way that makes sense for the department, because this is different than a nursing home. But to the extent that we can codify, we can make you able to do that. Let's put it that way, because very, very key, understand completely. You have your marching orders and what you can and can't do. So,
but I'm excited though, putting myself in a parent's shoes where I've personally been before. I have a little lived experience with that. I look at this and I do see that ability to be able to, sort by complaints and view by complaints and stuff. So I can already kind of do a process, albeit a little bit manual, but of, kind of filtering out like, well, yeah, I don't want him. This guy's got all these complaints. I'm going to go look for somebody who, doesn't have a whole bunch of, administrative findings against them or something like that. So at least we will have that, ability right off the bat for folks.
Right.
Well, and Martha, just a reminder to everyone. Hi, Angela Shave. I'm over the licensing here at the department. A reminder that we do have right now an interim status, which means that the provider is not in good standing with the department. They were on a regular, but during our inspection process, we found where there are deficiencies, and so we moved them to an interim status. So if you see somebody that's on an interim status, they're not in good standing at the moment, and they can work to get back onto a regular. So that is a stopgap until we have the statutory authority to make some of those rankings or, certifications on top of their license that we were discussing.
Okay.
Thanks, Angela. That's a great point. Yeah.
Thank you. All right. I see we have a hand up. Joanna Reed Henois. I'm going to allow public to chime in and ask questions. So go ahead.
Yes, quick question. I'm with the Community Services Department, Office of Behavioral Health and Substance Use Disorder. My question is, we all know that there are some providers that may be DCF licensed and some may not be DCF licensed. So the ones who are not, if they are not really playing, doing their part in terms of the services, who should we report that to? Is that a different like bureau? Like who should we be reporting those bad players to? Like who has the power in that case?
Well, if you're aware of somebody who's providing substance use disorder services and they're not licensed, you know, call our call us, call our licensing department. I mean, we have issued in the past cease and desist against folks who, are operating without a license. Now, again, without knowing the exact situation and all, and whether they roll up under ACA or under something else, I can't say, but I do know that is one of the things that we, that we're on the lookout for across everything that we license. Any type of unlicensed activity, we will take action to try to shut that down.
And from our office's perspective, we have it's called the Sober Homes Task Force, which used to be the name of this task force, hotline. It's on the state attorney website, and you can call because it's also criminal. You can't operate without a license. Now we're talking criminal, sir. We're talking substance use disorder services, not housing. Now the housing may or may not be a problem with that if there are referrals, but otherwise it's not illegal, it's not criminal. But operating without a license, if you're a provider, a treatment provider, absolutely call the hotline as well. So you have two places to go to.
Hey, Joanna, it's Michael Schlossman. We come across this all the time where we have a recovery residence operator who's providing licensable services. And we do exactly as was suggested. We report it to the licensing chiefs and they launch an investigation.
Okay, thank you.
Great. Thank you. Any other questions? Comments? Okay. Well, this has been great. Thank you so much. We've been talking about this for a long time. It's great to see it's close. And I don't want to hold you to it, but if you were to make an educated guess, when can Susan Ramsey go on and see the new sports car?
Well, our goal is to have all the trainings completed, everybody onboarded and through hypercare, really before we start getting into the holiday season. So, because for practical purposes, we're going to lose everybody probably over the holidays. So we're working hard on the user acceptance training. And at the same time, developing our testing, and at the same time, developing our training materials, which, we want to make sure that those are very robust and that they do what they need to do and that we have, the videos, the how-tos, all of that out to support people. So we're actively in that process right now. And, because we're still in user acceptance testing and it's going really great, but we could find like some bug tomorrow that requires some big workaround. So I hate to throw out any specific dates, but we're starting to feel confident enough that we should be sending out training dates very soon.
Awesome. Great. Excellent. Well, thank you so much. Thank you, team. All of you so much for coming and doing this demonstration. I'll be in touch with Senator Harrell. I think she'll be pleased as well. With that, let's move on to the next agenda item. And we've already had 2 special meetings of the task force on Chapter 419 rewrite. I think everybody who's on the task force has already received the same legislation, in an attachment probably 4 times now. What I'm actually going to do to just make this, um, not as brief as possible, but just, to speed things along. If anybody has any comments, questions, suggestions, just raise your hand and let's talk about it. We'll go to the line. I don't expect that we'll have any or many, because again, we've been discussing this for a while. We've had several meetings in August and September, and then in July as well. So seeing no hands, I know we have Dan Lauber on with us.
Al, I do have a couple of things
Okay.
to bring up.
Well, there you go. Okay, Michael, you
Thanks.
are up.
So a couple of questions, a couple of clarifications, and some of this is learned experience that we have in dealing with the municipalities who are coming to FAR with questions and looking for guidance on SB 954. And I think I talked to you offline about one of the unintended consequences of 954 is that the local zoning boards and municipalities have sort of woken up to the fact that they have jurisdiction over this. And they've gone out in certain circumstances where they didn't realize that, first of all, this was their job to do, and more importantly, that perhaps there was a spacing requirement, and they started measuring. So a bunch of our certified providers who have been there for years are now getting cease and desist orders. And it's becoming a real issue. So I was wondering if there's a way to grandfather in current providers into this rewrite, so that we don't have that same type of situation, and maybe we can even apply it to 954. We're looking for something to protect these providers who have been there forever. That's one issue. The other issue is I had a question for clarification. If we have a provider, a single, say, LLC who has 4 homes, and in certain circumstances, again, they're coming back to those 4 homes, which are all on the same street. And now they're making them move out of the ones that are 660 feet apart. And so, Dan, I had the same reaction. I was under the understanding that if it was the same provider, that was okay. So maybe you can give me a little bit of clarification about that. And if that's not the case, could we make it be the case? Because now we have providers who have multiple homes who are having to put them all over town, which really affects their ability to provide services and keep them part of the community. So
Well,
2 issues I just wanted to discuss.
before I hand it over to Dan, because I'm sure he'll be able to give a more detailed answer, but number one, a cease and desist order, if you're already there, you do have your reasonable accommodation avenue. So I don't know whether a cease and desist order is even appropriate, as opposed to just requiring someone to come in on for a reasonable accommodation. Number one. Number two, Dan, I thought everything was grandfathered in 419. I thought if you were already there, that it doesn't undo the certified residences that are already in existence. It will discomfort non-certified residences because they're not in compliance right now, but certified residents. So Dan, I hope Dan is still on. I think he is.
If not, I can try to answer that, Al. This is Terrell.
Okay.
He's on mute. He's trying to speak.
Oh, he's on mute. Okay, Dan, unmute yourself, sir.
Okay.
There you go. And then Terrell after Dan.
We've got the provision in here that it doesn't affect the authority of any community residents or recovery community lawfully established prior to January 1st, 2027 to continue to operate. So if at the time these were opened, they were opened lawfully, they get to continue to operate. It depends on if they were opened lawfully in the first place.
Yeah, and you know what? We did put 2027 on there to allow places that are already in existence to be able to certify, because then, I mean, there'll be an argument if they're uncertified that they're not lawfully in existence. So, so this gives time for for recovery. And now if they can't certify because they're, there's something wrong with them, people are smoking marijuana in there. Oh, all right, well, sorry. But so does that answer the first part of your question, Michael?
It does, and this is sort of cleaning up the files from far past. We have a bunch of certified providers, especially at level 2, who were approved for certification without proof of zoning. And so they never went for the reasonable accommodation. And they're, mom and pop organizations who barely, can scrub 2 nickels together to survive. And so now when they get, whether it's an eviction order, a cease and desist, a request for a reasonable accommodation, whatever the form is that they're getting, and it's various forms, their gut is just to give up and go out of business because they can't afford to hire counsel, and it's just too complicated for them.
Okay, Dan, you want to chime in on that, or Terrell?
Let Terrell handle it.
Sure. So I have a couple things, but to that point, when Delray Beach first passed its ordinance back in 2017, there was a provision where there was about 9 months between the time that the ordinance passed in July of that year until the following, I think it was April 1st, that people had the opportunity, or providers had the opportunity, to get FAR certified. And so they were grandfathered in, very similar to this proposed legislation, and they had that 9-month window to get FAR certified. And the city really provided them with some grace period for a while afterwards if they could kind of line it up and show that they were in operation. So I think that the way the legislation is drafted is somewhat similar and does provide for that window, and we will do a robust education to try to make sure that everybody is aware of that. And it doesn't require counsel, as you know, Michael, for them to just apply to be FAR certified.
Sure.
Aside from that, though, I thought it was interesting that you pointed out that people have awoken to the fact that they, under Senate Bill 954, at least that cities have awoken to the fact that they have some jurisdiction.
Not your jurisdiction, Terrell. They are alive and awake. Other jurisdictions.
Well, there you go. But I mean, in other places. But my point is just that, Senate Bill 954 did not impose distances. So if people have decided through Senate Bill 954 and the fact that they have to have an ordinance providing for reasonable accommodation process and providing, that they have to review and approve or deny the reasonable accommodations within a set period of time, and they're taking that to mean that they can suddenly impose distances. I mean, unless they're creating brand new ordinances to provide for that, I kind of question what's going on there. But
I'm not sure that's what they're doing. I believe that these would be distancing requirements that were already on the books that probably were not being enforced.
Under Chapter 419 or under?
Not sure, because when someone calls the FAR office looking for legal guidance or zoning guidance, we don't provide that. We do provide them with some resources in order to get the guidance that they need. So I don't have enough facts on every single. I do know Bill Green is handling one of them, and I left him a message, but haven't heard back yet to find out exactly what his client is going through.
I think the solution to this is twofold. Number one, we already have the grace period to come into compliance. Number two, if there was no zoning ordinance in place in the local, in the municipality, for example, they can't just pass one after 419 passes and then claim that the provider is out of compliance.
Right.
The one where there's a little bit of a gray area would be, as Terrell said, they already have an ordinance in place, but they weren't enforcing it. And I think maybe perhaps with a little wordsmithing, but if it wasn't a problem, okay, if it wasn't a problem with the ordinance in place, there's some kind of, and again, I'm a prosecutor, so I'm not giving any legal advice. I'm just giving my common sense says that an argument can be made that they waived it. Now, whether we can add a sentence or a line somewhere that closes that loophole where a residence that was not a problem can't be singled out because the local jurisdiction didn't see them as a problem and didn't do anything when it's kind of like they opened up, they're in existence, they're certified, they've done everything right, and now you're going to turn around and you're going to almost take away well, not almost, but just take away their right to exist after they've already been embedded in the community. So a kind of a long-winded way to say, Dan, do your best. See if we can, but I'm thinking that, and then the thing that you said, Michael, if they have to hire a lawyer, they're out of business.
Right.
Not everybody is an Oxford House, and that's, and that's an actual testament to Oxford House being all for one for all type of thing, where they can sue and they can be tough. But a mom and pop place can't afford to hire a lawyer. It seems to me that there's some kind of, not latches, I don't know what the term would be. Terrell, maybe you do, where they've reliance, I guess, some kind of reliance on the fact that they were allowed to be there. I don't know if that's legally even possible, but it would be a shame for this to be used in a situation where there obviously was no problem. I can see it if they've been complaining and wanting to get rid of them, and they're in the middle of a cease and desist before this or lawsuit. Anyway, does anybody
The
want
word's
to comment?
estoppel.
Right.
That's
Estoppel.
estoppel.
Thank you. See, you
Okay.
civil guys,
How
you know
how many
all.
lawyers does it take to look in a dictionary?
I know.
I was going to say
I
either
know,
estoppel or vested rights, but
Something like that.
I know writ of ad prosequendum. I know stuff like that, but estoppel, I forgot that 20, 30 years.
Yeah, okay, it's all right.
Yeah,
Terrell, you have
Michael,
your hand up, I think? No, Dan, you do. Okay.
Michael, if we could talk tomorrow or Friday or Monday,
Sure.
about this in more depth. I need a little more information from you to get a better picture of
Okay.
exactly what's going on.
Perfect. And how about the one provider under one LLC owning multiple houses and they're all on the same street?
That doesn't get you off the hook. It's not zoning has really very little to do with ownership of land. It's the use of land.
Hmm.
And, if it's a recovery community where they're all adjacent, then that's one thing. But if they're independently operating recovery homes or community residences of any kind, I'd like to get a little more information from you when we talk.
Well, yeah, and we could talk more offline about this, but the typical scenario is a DCF license of day-night with community housing, and they have, at least one male house and one female house, and they're both on the same block, and they're going to be asked to spread those out, which would cause, difficulty in the operation, take away from the sense of community, all fellowship, the whole thing that they're trying to do. Is there a way to provide for that under this bill? I guess that's what I'm asking.
Yeah, we'll have to talk about this, get a better
Okay.
idea.
Okay.
Okay, sounds good.
Yeah, certainly not for independently owned or operated, different type of people, but where it's part of a community.
Well, again, as Dan said, the ownership doesn't matter. So let's figure out if we can resolve this, because I think that's a big issue.
Yeah.
Yeah. But also, if they're already in existence, then I think that's a different issue to resolve. The grandfather.
These would be already in existence, right?
Yeah. So if we resolve the grandfather issue, then that may not eliminate, but it lessens the actual physical issue of somebody in the future.
Right.
But again, reasonable accommodation, which is explained and laid out in the legislation, you're bringing up some very, very good reasons why it should be allowed as a reasonable. One of them should be allowed as a reasonable accommodation. unless there are countervailing issues with regard to the community, and I can't see it. So, again, either way, but you guys will talk about it and let me know if we need to tweak the 419.
Sounds good. Thanks, Al.
Sure.
Thanks, Dan.
Any other comments on the legislation?
I just had, this is Jill. I just have a quick question or a comment. I couldn't find how to raise my hand, so I apologize.
Oh, no worries.
I would that not fit under the recovery community provision within that the revamp legislation? If I recall correctly, there was that kind of recovery community.
Yeah, the recovery, as Dan said, the recovery community they have to be adjacent to each other. You can't have like a triplex and then two privately owned triplexes or duplexes, and then further on down the block. When I say you can't, I mean it's a permitted use, not reasonable accommodation, but as a permitted use where you don't have to go through a zoning process at all. If the recovery, and Dan, tell me if I'm wrong, but a recovery community are adjacent structures or apartments.
Yeah, you're right. We've got to, we're trying to maintain a fair and balanced statute, and let's not kid ourselves. If someone's got a home and you have recovery communities open up a group, community residences of any kind open up next to them on both sides, they're going to take a hit on their property values and mode of living. So, we're making a reasonable accommodation in the zoning to allow for the recovery communities having adjacent structures. Aside from having a whole apartment complex, as we have show in the study, last year's study, we're allowing for, you could have, a series of single family homes, a series of townhouses, a series of duplexes, a series of triplexes, a series of quadruplexes. But we really need to maintain them as being adjacent in order for this to be fair to the non-disabled people in the on the block and in the neighborhood.
Gotcha.
Now,
Thank you.
again, we do have
Yeah.
reasonable accommodation there.
We do
So
have-
when you have a scenario with like the male house and the female house, that's a perfect example of something where a good case could be made for reasonable accommodation.
Right.
And I know there's an economic model, and I'm going to say this because, this is the 1,000-pound giraffe in the room. There may be some ingenious tweaks that can be made down the road, but the main thing about 419 right now is for the vast majority of providers, you're going to be able to walk in and just fill out some paperwork and not have to go through a reasonable accommodation process. So, there are going to be outliers, and I'm very well aware, and so is FAR, and we have a number of people that are regulars on the task force here that it is a problem for certain business model, certain model of level 4. And this is not going to be the conduit because we'll never get it passed if we do everything for everybody. So that's my 2 cents. And thank you, Jill. Anybody else have a comment or a statement?
I actually just have a comment. I found a typo that we need to correct on line 303. We define local government as a county as set forth in chapter 125, and then it says chapter 7. It's not chapter 7. And then or a municipality incorporated under the provisions of chapter 165. So the rest of it's right. It's just that extra chapter 7 that's in there. I just figured while you're asking, I would mention it. I just saw it last night when I was preparing for the meeting today.
Okay.
Thank you.
When we get it back from this is really not a problem. When we get it back from staff, we'll have to deal with changes anyway, and this will be one of them. Okay.
I think I'm just mindful of it because we're presenting to the Florida League of Cities next week. So I just wanted to make sure that we at least look like we know what local government is. Sorry.
Yeah, that would, yeah, right, right. Thank you for that. See you there. Um, okay, any other comments? We have one short agenda item, number 5. I just want to make everybody aware of the Tristan Murphy Act. It was passed in the last legislative session, and it's a good thing because it is offering the establishment of mental health courts for felonies. We actually in Palm Beach County have a hybrid where we're not only allowing competency, but also people with behavioral health issues and trying to get them services in terms of misdemeanors. But there is no felony mental health court in Palm Beach County. There's a competency court, which is only for training people who commit crimes when they are not competent to proceed, but nothing in terms of treating the underlying condition. And there are a series of grants. And my understanding is Palm Beach County is going to be looking into obtaining these grants to start the court. And I'm going to be involved in going to those meetings, either myself or the Deputy Chief Stacy Ibarra. So just wanted to let everybody know it's a good thing, but it's money. I mean, you have to have the services provided, and the services need to be reimbursed. And I'm sure that I know they're not here and probably would have something to say about this going forward, but this will involve the healthcare district. It's likely to involve rebel recovery, I would imagine, on the substance use disorder side. It will involve the jail in their programs. It probably will involve Southeast Behavioral Health Network. So it's an all hands on deck type of thing, which is, it's a good thing if we can get the grants and get it going. So just want to let everybody know that's that exists, and I'll keep you posted if anything is moving. So with that, any questions, comments about anything from today from the Addiction Recovery Task Force? And then I'll open it up to the public. Anybody have anything they want to share? And again, there's been a rumor that our Sober Homes Task Force is not there. We are there. We do have investigators looking into any hotline tips that we get, and if there's something there, we may probably do a cursory investigation and talk to witnesses, and then refer the issue to local law enforcement. We no longer have 8 or 9 investigators that are parked downstairs on the first floor of our building. I think we're a victim of our own success here in Palm Beach County, which is a good thing, but don't want to open up the door to have the bad actors come back. Any farewell comments? If none, thank you so much. And again, I got you out of here early, not 4 o'clock. We'll see you in 2 months. I'll keep everybody posted with anything that comes in with, we'll send you out stuff from time to time on the legislation.
Thank you, Al.
Thanks, Al.
Thank you.
Good to see everybody.
Thank you.
Thank you.